right. Welcome, everybody. What a crowd tonight. Thank you for coming out and braving the heat that we're dealing with that just doesn't seem to want to end. I'm Ryan Parker. I'm an emergency physician by training, and I'm the Chief Medical Officer for the Yale campus here. And it's my pleasure to welcome you tonight and introduce our speakers, Dr. Reed and Dr. Gursky. So they're two of our orthopedic surgeons. Just to give you a little bit of a background, both Tulsa boys, born and bred, and came back home after training. Dr. Reed completed his undergrad and medical training at OU, and then he spent 10 years after training in the U.S. Army serving, and then came back to Tulsa to serve you all. Dr. Gursky completed his medical school in Kansas City, and then stayed in Missouri for residency. They both specialize in hip, knees, and then Dr. Reed specializes in shoulders too. And I will tell you, we have an OU, an OSU, and a Longhorn in the middle. But what unites us all is the pink and the St. Francis community that we serve. So very thankful to have you here and very excited to hear what you guys have to say tonight. So welcome.
All right. Thanks, Governor. All right, can everybody hear me? I tend to get kind of loud. I don't really need a microphone. I'd like to say thank you, Dr. Parker. It's nice to meet you. Thank you for having us here. Dr. Gursky, I'm getting to know everybody here. I see some faces in the crowd that blessed me tonight. It's so nice to see some of my patients here, and maybe we'll get to know some of you others as time goes on. So as Dr. Parker mentioned, I'm Dr. Reed, and I'm going to figure out how to do this. And so I made this pretty basic because it's really, really, really complex, but we can get kind of muddled in the weeds. And so we're going to make this kind of basic. And title, as you can see, Do You Need a Joint Replacement? And so a little bit about me. Dr. Parker already mentioned, I have some letters and stuff after my name. That's my wife. We've been together for 30 years, and I'm very blessed to have her. So what is joint replacement? A lot of times people show up in our office and they think, okay, well, my knee hurts, my doctor says I need a joint replacement, and they think we're going to chop your knee out or chop your hip out or your shoulder and stick something else in there. And really what it is, the term for joint replacement is actually arthroplasty. Arthroplasty means resurface or interposition. So that could be fat, it could be muscle, it could be a tendon, it could be metal and plastic, as in the case of most of the stuff that I do. But we want to keep your soft tissues intact, ligaments, muscles, those bony attachments. And in some rare cases, we may require more aggressive resections. So why would you consider this? The most common complaint that we get for people is pain, right? Somebody says, Mom, my knee hurts or my hip hurts. Instability may be a presenting symptom, deformity, prior trauma, and loss of function. You can see this picture of this guy here. This is one of my patients currently. Those are pretty bad, right? And so there's arthritis sort of is the catch that we talk about. For most people who present for a joint replacement, it actually comprises over 100 different diagnoses. The ones that we most commonly deal with are osteoarthritis, which is wear and tear, right? You've had enough years on your body and the joint wears out and it starts to hurt. But then there's inflammatory, post-traumatic, congenital deformities, and in rare cases, infection. So when should you consider this? A lot of people will show up and they'll say, I've done nothing, but my knee hurts. And so in those situations, we want to try everything under the sun that we can do to try to keep you out of an operating room, right? And then in some cases, it's why I have a job that doesn't work and we end up in the operating room. But it's been proven that therapy, non-steroidal anti-inflammatories, steroids, physical therapy, viscosupplementation, I'll talk about that in a second, and embracing can help people in certain situations. Viscosupplementation is the rooster shots. Have people heard of these things? The literature on them is somewhat sparse, and so a lot of the insurance companies have stopped paying for them. So we will do them for people in my office, but it's not really a mainstay of my practice anymore. So when all else fails, surgery. And I think that's what most people came here to kind of understand what surgery is. And so I'm going to show a few examples. So the goals of surgery, number one, we want to reduce pain. It may not eliminate pain, but we want to reduce pain. We want to correct your alignment. A lot of times, as that picture I showed you a minute ago, pretty significant deformities. We want to correct alignment. That helps the joints last longer, restore stability, and ultimately improve your function. So As I said, people don't really want to hear me talk. They want to see pictures and know what things are. This is the most common knee replacement that I do. It's somebody who's got the inside of their knee hurts. They're starting to get bow-legged. They limp, and they come in and they present. So if they've tried steroid injections, if they've tried physical therapy, they've tried weight loss, they've tried exercise, then we may get to the point where we do a knee replacement. This is an example of what we call a primary knee. And so we resurface all three compartments. There is a partial, and I didn't throw a picture of a partial in here. Partials in my world are very, very, very few people, but all we would be doing is replacing that part right there. Does everybody see that? All right. So they're a very, very small fraction of most people's practice, and then there's a few surgeons out there that's all they do. And so I kind of leave it to them. Here's an example of a complex primary knee. So this lady had prior surgery. She'd actually had an osteotomy to try to offload a portion of her knee, and she just kept falling into what we call valgus, which is a knock knee deformity. And ultimately, I had to do big osteotomies on her, and she's one of my favorite patients now. Here's another guy. This was a person, this is an example of what we call a revision knee. Right? So somebody's already had a joint replacement. Show of hands, who's already had a joint replacement? I know one. Yeah. So there's some people in here. So if the knee starts to hurt down the road, we need to look at it. And you'd know if this happened, obviously, but if it falls into a big deformity like this, I had to reconstruct this one with this right here is actually a cadaver femoral head that we built into the medial side of the tibia to make up for that big bone loss. And that guy's done well. Here's an example of primary hips. Arthritic change in the hip right here. You can see there's no space there. If you compare it to the other side, which isn't awesome, she's already got arthritis on this side too, the joint space is not there. Hallmarks of osteoarthritis are cyst formation, loss of joint space, sclerosis, which means hardening of the bone, and peripheral osteophytes, which are bone spurs. And so that's an example of a primary hip. Complex primary hip. So this is a patient that had congenital deformity. So you've heard of kids that are born with the hip and they have to put the brace on, or like Forrest Gump had to walk with the braces and stuff. So that's hip dysplasia, and that's what she got her hip replacement for. She's very young. She's only 36 years old. Here's an example of a revision hip. So you can see this one right here is sitting inside of the pelvis. It's not supposed to be like that. And so in that situation, we went back and bone grafted and put in a bigger cup. And I had to this is a very, very complex procedure, but lucky to say she's done really well. So then there's primary shoulder, the hallmark of a primary shoulder that doesn't show up great on this x-ray, but this big bone spur right here. And usually this presents as a loss of motion, pain in the shoulder, but really, they get to the point where they can't reach behind their back, they can't reach their hand up in the air. And so this is an example of a primary shoulder. And a primary shoulder, the most important thing is that you have an intact rotator cuff. If you don't have an intact rotator cuff, then you get this. And so this lady, as you can see, the humeral head is sitting up very, very high. She started to wear away the acromion above it. She's had a prior rotator cuff. That's what those little dots are right there. They're anchors from a previous surgery. And so this is what's called a reverse shoulder, where we flip the shoulder socket. And so one of the things that I didn't mention in my previous slides is like what we do to get you ready for surgery. And so I'm just going to speak to this off the cuff. We want to make sure that you're medically optimized, because most people who are old enough to need a joint replacement probably have some other medical issues, whether it be high blood pressure, heart disease, kidney disease, diabetes is very common in our practice. And then there are other self-induced comorbidities, things like smoking, potential problems with weight gain, et cetera. And so there's some criteria that we want to try to get people to get to, whether it's getting their BMI down if they're overweight, because we've got a lot of literature that says that people do better if they can get their BMI down. We want to get you to quit smoking. We want to get your hemoglobin A1C. In my world, I like it under 8. A lot of our criteria is 7.5. And if you're diabetic, you know what a hemoglobin A1C is. We want you really to be down in that 5.5 range, and that shows really, really good control of your blood pressure, because all of those things, when they're out of order, can lead to you having a risk for a complication. The risk of complication in joint replacements can be pretty devastating. So to keep this kind of short and sweet, because I know people like to ask questions, joint replacement essentially means resurfacing. As those examples I showed you, major indications, pain and loss of function. And treatment, we want to attempt all the non-operative therapies first, and if that fails, we'll go to surgery, okay? And that was my talk. Thank you. I'll sit with you.
Okay. Okay, can everybody hear me okay? All right. So first of all, a thank you to Ryan Parker. Appreciate the opportunity to come and talk. Very much, very much. Great name. And Scott, I've had the fortune of working with Scott now for the last couple of months. As total joint surgeons in the Tulsa area, in a small area like this, we kind of all know the names, but we don't always get to meet each other. And so Scott has worked here for probably 7 or 8 years now, at least. I've been at Tulsa 8 years. So I've heard his name multiple times. I've never personally had the pleasure of meeting him, but now that I have, he is a wonderful surgeon and a wonderful person, and I appreciate the opportunity just to come and talk with him about this subject. For clarity, I am Dr. Ryan Gursky. I am board-certified orthopedic surgeon, but I specialize in adult reconstruction of just the knee and the hip. This was a chosen specialization, so to speak. I came out of practice or out of my training, and I did a little bit of everything. I did shoulders, I did feet, ankles, hands, but I found a passion for doing joint reconstruction. So I really tried to hone in my skills and my practice into just those specific areas. I am the lead physician at the St. Francis Joint Replacement Center, and we have some folks around here that represent the Joint Replacement Center, Sydney Staten, our coordinator in the back, and multiple of our employees that work back there. And this was something that we dreamed up about probably 7 or 8 years ago, and it has far exceeded anything we anticipated as far as just the accomplishments we've made, the patient satisfaction, and the outcomes have been remarkable. What is my agenda? Well, in this lecture, you've got 2 surgeons that are coming up talking about the same thing, and as good of friends as we are, we didn't communicate a lot about what each other was going to talk about. So I might be kind of reiterating some of what Scott said in regards to the joint replacement. So some of these slides might be a reiteration of what you've already heard. I'll try to give a little more clarity, and I'm going to talk a little more about that post-operative period in the process of joint replacement. As far as agenda, what we want to try to learn, one, what is a knee and hip replacement? I think Scott answered that really well. So Dr. Reed did a great job kind of explaining what it is, because, and we'll get into that a little bit more. We also want to learn about what I can do to prepare as a patient. Again, things that he's covered. We'll get in a little more detail of things that can be done preparation-wise. Understanding what to expect the day of surgery. So now we're getting into the nitty-gritty. What is it going to be like? What am I going to go through if I sign up and I decide to have a joint replacement? The evolving options of post-operative care. I put that in there. It's kind of a wordy thing. It basically means, where are you going to go when we're done with surgery? Are you going to go home? Are we going to stay in the hospital? What are the best options, and what's available to the patient? Finally, what to expect in those weeks following. Dr. Reed, again, was very good at pointing out what arthritis looks like in the knee. Here, it's just another example of what we would have a normal knee versus the arthritic knee on the left. Bone contact, extra bone formation, deformity, these are all things that indicate arthritic change. What is really happening in a joint replacement? Again, Dr. Reed told us this, but I think the most common question or the most common statement I get in office is, after I've explained the process, they say, oh, I thought you were just going to literally cut off half of my thigh bone, half of my shin bone, and put in a bunch of metal. That is, I hear that at least 4 times a day. And I got in, a side note, I got into a habit of telling patients it's resurfacing. And I learned you had to be really careful about how you talk to patients and how you explain things. Because I had a patient about 5 years ago that refused to sign the preoperative consent in the preoperative area because it said total joint replacement, total knee replacement. And I explained to her that it's more of a resurfacing. is how I tried to term it so she could visualize what we were doing. So she refused to sign the consent until I could come and explain it once again. So we do have to be a little careful, but I think in the sense of what we're talking about here is if we want to get a true concept of what we're doing, we're resurfacing. We're not removing a bunch of bone if we don't have to. We want to preserve bone. We want to preserve soft tissue. We want to eliminate bone contact. That's our goal here, eliminate the bone contact. So the joint is being resurfaced with metal and plastic in the case of knee replacement. We're correcting deformity. He showed you some really great deformity slides. Deformity probably makes up, that degree makes up about less than 5% of our knee replacements, those big, huge deformities. It's more of these more subtle deformities with a little bit of what we call bow-leggedness or a little bit of a knock knee. Those are going to be our typical joint replacement patients. Removing extra bone, everybody hears them as bone spurs. We'll hear them termed osteophytes, but these are just extra bone projections that are occurring because your body is responding to that arthritic process, that cartilage loss. So that's just for us a sign that this is a more advanced process. Last is soft tissue balancing. This is just to achieve what we want for range of motion, stability, and the ability for you to do what you want to do. Hip arthritis, again, it's really a comparison between the normal and the abnormal. You typically are looking at bone contact in the hip. You're looking at deformity. I always tell my patients, see how your ball doesn't look like a ball anymore. It looks more like a pancake. That's the arthritic progression. Here we're seeing some examples of what we call some, let's see. There we go. We're seeing the subchondral cyst. So these are things that can happen underneath the bone. So oftentimes if patients nowadays on my chart, they get their x-ray reports. So you get this report from the radiologist. Radiologists love to use words. So they will typically get patients very worried about what's happening. And oftentimes you'll hear cyst, and they'll say, I've got cyst in my hip. Does that mean I have cancer? Is that a bad thing? Well, these are what we call subchondral cysts. Subchondral cysts are a reaction and an arthritic progression. So that's just the weakening of the bone underneath that starts to create that collapse. So what is a hip replacement? In a hip replacement, exactly what you see here. We're going to be removing that arthritic ball. We're going to be using a stem to place down inside of the thigh bone so that we can place a new ball into position. In that process, we're also going to place a new cup. So we're going to replace the ball and the cup. That's what makes it a total hip replacement. There are replacements out there called hemiarthroplasties. These are things that you might have heard of if somebody had a fall and a fracture. In a more elderly patient, sometimes we'll just decide to replace half of it, especially if they don't have a lot of arthritic changes on the opposite side on that cup portion. We want to reestablish hip range of motion. So important, most patients with bad arthritic hips, that's the first sign that they've got something wrong. They can't put their shoe on anymore. They can't tie their shoe. They can't place a sock on that foot. You lose a lot of range of motion when you have the arthritic changes in the hip. I always tell my patients it's like a square peg in a round hole. It just won't move right. So approaches to the hip, it's for a whole nother lecture. I threw it on here. I think it's minutia, but there are lots of ways to get into the hip to replace it. They all have their advantages. They all have their disadvantages. And so that's something just to talk about with your individual surgeon as to what their preference is and why. As a kind of a progression, this just kind of shows that process of removing the femoral head up here, maybe. Oh, no, I'm not going to get it. So removing the femoral head, reaming the acetabulum, placing a new cup is what that means. That cup is made of titanium. There's a plastic liner inside. That is the new cartilage, I like to tell my patients, is plastic. That reaming of the thigh bone is just to place the stem down, and then we can have a new housing for that new ball. So we'll get into more of the meat of this now. So preparing for joint replacement. I think it's important to know if you've at that point established with your surgeon that it's the best thing for you, what do you got to do now? What's my next step? Well, first is to discuss the process. What you want is you want information. You want knowledge. Knowledge equals success. Knowledge equals comfort. It decreases your stress the more you understand what you're getting into. So hopefully from this, you'll get to understand a little bit about what that process is and what to expect. Like Dr. Reed said, you definitely want to discuss those chronic and acute medical issues that you may have going on. They affect outcomes. They affect the process. They affect your potential disposition of where you're going to go following surgery. So it's very important that we discuss those medical issues. Next, we want to talk about any past experiences, any issues you've had with surgery, with anesthetics, and that process and healing wounds. And then discuss sensitivity of metals or materials. There's that theory out there of, can I reject an implant? And the answer is, you won't reject it, but your body might tell you it doesn't like it, okay? And what that means is there's some people that are sensitive to certain materials. And so we have to be cautious because we're placing foreign materials in your body and they're going to be there for good. We want to make sure that you don't have a sensitivity. Sometimes if there's a high suspicion, we've got to do sensitivity testing before we go through that procedure. Physical preparation, certainly weight loss. I've actually had one patient I've had to gain weight before surgery. So it's happened to me once now. But weight loss is always beneficial. You will always benefit from losing weight before the surgery and preparing your body. Strength and flexibility, that's probably even more important because your post-operative outcome is going to be based off of your preoperative abilities. So as much as you can build up your strength and flexibility, it's important. Health and medical optimization, I think Dr. Reed covered that well. Big ones for us now are going to be that hemoglobin A1C and then what we call our BMI or our body mass index. Those are things that we really look at. And so those are things that can predict outcome and potential complications. Home and environment preparation. This basically means start thinking about what you need to do. What do you need to do at home to be successful following the surgery? Whether it be your bed location, are you upstairs, are you going to have to climb stairs? Can you position yourself somewhere downstairs so you don't have to for a week or two? Toilet extensions, handrails, reducing obstacles, rugs. We don't like rugs post-operatively. All those little neat, cute, frilly rugs, they can be a hazard when you're talking about a post-operative setting on a patient that's getting around with a walker. Support, individual and group. Who's going to help you? Who's going to be there for you afterwards? And then think towards timing. My common statement to patients is, I do surgery year-round. It's got to fit into your life. It's got to fit into your schedule. Don't come and tell me you want a joint replacement, but you've got this big trip to Europe in 4 weeks following that. Am I going to be ready? Because I'm going to tell you no, right? So you've got to be able to plan your life according to this process. What to expect the day of surgery. First, you will be told nothing to eat or drink after a certain amount of time. I harp on this one because inevitably you don't want to be that person that comes in chewing the bubble gum or eating the mint when you're walking into surgery, because the minute somebody sees you doing that, we've delayed your surgery by about 8 hours. So the important thing to remember is they will be giving you information in that preoperative setting of when you're supposed to stop eating and drinking. Follow those instructions. Dress comfortably, pack clothes, pack accessories. You might be staying in the hospital a day or two, so be prepared for that. Understand the family will be able to remain with you in that preoperative setting. So post-COVID, pre-COVID, things kind of changed around a little bit. There was not a lot of accessibility for additional people. Your family members will stay with you until the time of surgery. Once we go into the operating room, then they'll go into the waiting room and wait for you there. As far as preoperative meds, IV, skin prep, this is what we're doing, and this is why we're showing up and arriving at the hospital 2 hours earlier. You can see, everybody always says, well, why do I have to be there so early? Well, there's a lot to do before we get you back there. So it's important that we get there on time and we be prepared. Understand that there's always a possibility that you're there a little longer in that preoperative setting because things can happen. The operating room is a very dynamic place, and we operate it much like you would an airplane. And if there's a least bit of a problem with the airplane, we're not proceeding until we've solved that problem. So sometimes there can be delays or things that are going to take a little bit longer, but the average time is about 2 or 3 hours. Operative time may vary. That's surgeon dependent and case dependent, but the operative time will be variable based off of that. Generally, we're calling out, talking to family if it's going to be a longer process. You're typically going to get from the operating room, once surgery's done, you're going to go to the recovery room. That's usually about a 1 to 2 hour stay. That is where we're kind of getting our postoperative pain control, and we're making sure that things are stable. So you're being monitored constantly with one of the staff in the recovery room to make sure that everything's okay. The last line there, the Joint Center floor, I gave my shout out already, but I'll give it again because they're phenomenal people. Generally here at St. Francis, we will go up to the Joint Center, which is 5 South. That is kind of our recovery floor where we're going to be overnight and where you're going to start the therapy process. The great thing about these guys is everything I've talked about before, we handle that in our Joint Center by doing classes before, usually a week or two before your surgery. You're actually coming in and you're talking to these folks. So you're going to sit down with Sydney and some of our therapists and some of our nurses, and you're going to learn what it is to expect. So you're going to see all of this stuff again. Postoperative care. This is where we get into kind of that disposition side of it. Where am I going to go following surgery? Well, I never heard this 20 years ago when I started. Nobody ever said, do I get to go home the day of surgery? They usually said, I'm going to be here a week, right? You know, that's the general expectation back then after a joint replacement. But that is a common statement now is, am I going to go home right after surgery? So the answer is it's variable. It's dependent. There's options. And I want to kind of just cover a few of those. The most common, or the one that we always hear about, is inpatient admission. From us, that basically means you're going to be in 2 midnights, right? You're going to stay 2 nights over. That's an inpatient admission. It's usually the length of stay, like I said, used to be 3 to 5 days. We've got that down to like 1.3, 1.4 right now is the average length of stay following a joint replacement, but that's decreasing. That's continually decreasing for us. It's usually those patients that have multiple medical factors. So if you've got a lot of these heart issues, kidney issues, men, if you're going to have the surgery and you've got trouble urinating and you've got urinary issues and prostate issues, there's a chance that you're going to be staying because we got to get you doing these things before you go home. So these are things that can keep people in that inpatient admission. And then limited home support or lack of home support. Obviously, we can't send people home if it's not safe. Outpatient, that outpatient alternative. That basically is something that's evolved over the last several years, but it's become very highly sought after. There's a lot of people that really are looking for this outpatient. What does that mean? Well, it means you're basically going to go home the day of surgery, not always within an hour, but you're going to go home by 5, 6, 8 hours after surgery. You're going to be assessed, you're going to be worked with a therapist, make sure you're safe, and you're going to go home and do the recovery at home. That's usually our very low risk, low medical issues. They've got a lot of home support, high functional ability preoperatively, and they really don't want to be in the hospital, right? They just don't want to stay overnight. Outpatient to bed status, this is probably the most common that I do because it allows my patients to stay overnight, but then they go home the next morning. It's not a true inpatient admission, but it does allow us time to assess, evaluate labs, and then go through the therapy process to work with our folks in the Joint Center. Inpatient rehab, skilled nursing facility, these are important to know. They're kind of tough to get into anymore. So inpatient rehab is not an easy process to get into. And very few joint replacement patients qualify actually anymore to get into a inpatient rehab setting. So we're going to run through this, and I might speed up a little bit because I know we want to get into the questions, but basically talking about the recovery process. I'm going to walk you through kind of each week, but we're going to do it at a clip of a pace maybe. Week 1, first 24 hours, always remember you've had some form of a block or you've had some form of a numbing medicine put in. I like to call this my honeymoon period because my patients love me still, right? I go and see them and they're like, you're the best. This is great. I don't hurt at all. And I'm like, okay, give it about another 5 hours. When that numbing wears off, you're going to start feeling a little bit, okay? And it's a surgery, and it's going to come with a little bit of discomfort. So remember that you've had that block. Remember we don't want to overdo too much in that first 24 hours. We will immediately ambulate, though. What we have found and what we believe at the Joint Center is early ambulation is the key to everything, getting up and moving. So we want to really promote that within hours of getting up to the floor. We want to start that process of walking and ambulating. Beginning range of motion and working on gait stability. This is our ability, 1, to make sure you're going to be safe going home, and then 2, we're starting to move that knee. I tell my patients, without a doubt, I don't really care how far you've walked in 2 weeks. I'm going to ask you how far you can bend it, how much you can straighten it. So that's my main focus for the first 2 weeks. It's important to get up and move. We've got to be doing it, but I want to see how much we can work that knee. When we talk about hips, so we throw that into the week 1, you were talking about hip precautions. So then now these hip patients that have had a replacement have to understand, depending on the approach, depending on any intraoperative issues that maybe came up, there may be some restrictions on your movements, what you can and can't do. This is our opportunity to educate you on that. CPM, some people use it, some people don't. Again, it's surgeon dependent. I'm a CPM user, I believe in them. Some people don't, it's okay either way. It doesn't change the 8 to 12 week outcome, but it does, in my opinion, change that week 2 to 4 where you're moving a little bit better. Daily physical therapy. We're working on pain control, ice elevation, narcotic, non-narcotic medicines. What's our right combination to control your pain and symptoms? Blood thinners get started on post-operative day number 1. Variable, but I still use aspirin. I use a full-strength aspirin for my blood thinner. And unless there is a high-risk patient that has history of blood clots, then you have that potential of having a oral blood thinner or even injectable blood thinners. But that will be carried on somewhere between 3 to 5 weeks out from surgery. And you'll have daily ambulatory goals, how much we want to be getting up and moving, how often. Week 2, this is where you know you had your knee replacement, okay? The honeymoon period's over, and we're still pushing you, and we're starting to feel a little bit more, we're starting to get a little more swollen, so this is where it takes a strong mental attitude at 2 weeks, in my opinion. We're going to continue daily therapy, but it's only going to be directed by a therapist 2 to 3 days a week. You have the option of home therapy versus outpatient therapy. Basically, you can have somebody come to the home and work with you, or you can go to a facility. That's really dependent on your functional ability and your accessibility to getting out and going to a facility. Again, I don't know that the long-term data has shown us any difference, but a lot of us will push for that outpatient because it tends to produce a faster result from an outpatient therapy standpoint. Continue CPM, I continue it through week 2. If nobody uses them, then you're not going to be using it at week 2. Transition to a cane. Basically, I want my patients being able to transition to a cane at 2 weeks. That's the period of time where you should be really almost full weight bearing, but you need that cane just for the stability side of it. My hips, however, at 2 weeks will typically come in doing cartwheels down the hallway because they are already walking. They've already been walking for about a week. They recover faster than knees, and it's just the way it is. Hips are about half the recovery process. So everything I'm talking about here with knees, you half that, and that's about where hips are typically in that process. The first postoperative visit is usually at 2 weeks. That's a wound check. That's to make sure your range of motion is working well and to make sure that everything is going well from a prosthetic standpoint. Typically, you'll get an x-ray at that point. That's where you'll finally get to see what your knee looks like on x-ray. Wound closure removal, that's where, again, we're dealing with the wounds and making sure everything is healing up. I will typically release you to get your incision wet in the shower at 2 weeks, but no soaking. Weeks 3 through 5, so we're going to build it up a little bit. We're going to stretch it out a little bit more. So week 3 through 5, this is probably your hardest working time. You're already making gains, but we're pushing you just a little bit more, and we're going to actually add strengthening into it now at week 3 through 5. So we're going to add a little bit more stress to that recovery. Everybody should be doing outpatient by week 3 through 5. If they're not, it's typically more of a social situation where they can't get there. We're going to continue those final range of motion goals. Release to drive, I've usually released between 2 to 3 weeks. Most of my patients, if you're full weight bearing and you're not taking narcotics. So, those are probably the biggest stipulations for me. You're full weight bearing typically without any assistive device with knees. And again, you're being discharged. And you can see lower down, my hips are typically released to full activities at 4 to 5 weeks. So I'll let them go do whatever they want. Return to work, this is where we can start talking about that with patients that don't have a real physical job. They can return to work. If it's real physical on your feet, you're not ready at 3 to 5 weeks typically. 6 to 8, final push of range of motion. Formal therapy is decreasing, you're going once or twice. We're now working mainly strength and endurance. We should have kind of the basics of our range of motion, and we're working more of the strength and endurance side of those muscles. Most people can start returning to work around that 7 or 8 week period to more physical jobs. I want to start assessing and making sure you have that normal gait pattern by 6 to 8 weeks, that heel to toe walk. You're not shuffling, you're not protecting, you really got that normal stride. We should be discontinuing narcotics. I really think we should probably be doing it before 6 to 8 weeks if we can, and I tell my patients as soon as you can get off of them, please do, okay? Some can't, but if we can, get off them, and let's find another way. Continue to control swelling. You still will have swelling at 6 to 8 weeks. It won't be as significant, but it'll still be there. And you will still know you had a knee replacement. So anybody that tells you that they went at 6 weeks and they didn't even know their knee was replaced is telling you a story probably, because you'll still know it. It doesn't feel like your knee yet. It just doesn't feel like you yet. You might not have a lot of pain with it, but you'll know it was replaced. 9 weeks and beyond, basically released activities for everybody. We want to return to our preoperative higher demand activities. I love the pickleballers. I think that they're some of my favorite patients. They are so passionate about pickleball. So I love them. PT should be self-driven at that point. You should be able to do it on your own. Maintain strength and flexibility. This is what I harp on with my patients all day, every day, and I see them every year. From the day I put it in, I'll see them once a year after that until they just get tired of me. And I will tell them every time, you can't be too strong and you can't be too flexible. Continue regular follow-ups here to monitor the prosthesis. Everybody's a little different. Some people will say, come back and see me at 10 years. That's where you might start having problems. Some at 5. I just say I want to see you yearly because I want to follow the pattern of what's happening with your implant. That's just me personally. Travel needs. Obviously, you've got metal in. You're going to need a card to get through the airport. It's not going to matter. You're still going to get wanded. I always tell my patients, I'll give you the card, and you can go and you can tell them you had a joint replacement. They're still going to wand you, but it might make the process a little quicker, and we do give out those implant cards to let people know that you have that in place. And that's kind of the time where we start considering undergoing the opposite extremity. So patients that have bilateral knee problems, both knees or both hips are bothering them, this is about the time frame at 9 weeks where some people might consider doing that. It's most common between 6 to 12 months that people will go through it again, but I have some go-getters that want to do it 9 weeks later. And that is partially my family. I've got a couple in there that are older that didn't want to be in the picture, but but this is my wife and 4 of my 6 kids. Anyways, the other 2 are too old, but and that is it. So thank you.
Thanks to both of these gentlemen. This is really sort of the partnership between Tulsa Bone and Joint and Warren Clinic Orthopedics has been this beautiful blossoming piece, and we're so proud to have you both here at St. Francis, truly to be a center of excellence at St. Francis. We want to serve you and the Tulsa community and give you the best care that we can. So thank you guys for giving your expertise.
My pleasure.
I know you all have a lot of questions, so I'm going to be the what's the old
moderator?
show? The,
Yeah. Oh,
moderator.
We say Bob Barker, but don't, because he's gone now.
So if anybody has questions, I'll come give you the microphone. If not, one of the things in the ER, just to get you guys started, I will see people coming back with infections, maybe, a couple days, couple weeks after the surgery. So maybe would you guys talk about some of the pre-work? I know you mentioned it briefly, but Sydney and her team, some of the stuff you'll do before surgery to maybe diminish that risk for infection afterwards.
Absolutely.
Want to take it?
Okay. So again, when it goes into optimization and preparation for surgery, we have certain aspects of surgery that present a higher risk. One thing in total joints that we look at, and I touched on, was the blood thinner side of it and blood clots, but then the other is infection. So what we understand is that obviously there's multiple factors that come with the potential for infection. Part of that is that preoperative workup and understanding where a patient falls in that risk category. So we'll check up those labs. We'll do those labs beforehand, and we'll see if there's any potential risk. I still do a urinalysis to see if there's any potential for a urinary tract infection. You will get IV antibiotics preoperatively, intraoperatively, and postoperatively through the IV. It's usually for the first 12 to 24 hours after surgery. When it comes to the potential for risk, I always tell people, look, everything we do from an operating room standpoint, the sterility, we have top-of-the-line ORs and equipment and technique here, but we still can't make the risk zero. It is an impossible thing to do, but we're constantly trying. Patients can help us with that, and that is really making sure that they are following the directions on wound care, following the directions on what they allow to be if they allow their wound to be exposed to things. And then second is not sitting around wondering if there's an infection but not telling anybody, not communicating, okay? What I hate is when somebody comes in at 2 weeks later and they go, well, my knee's been really red and swollen and draining for the last week. but I figured I had this appointment a week later, so I thought I'd wait till I got here. No, we want to know that now. In fact, at St. Francis, what we've established through the Joint Center is we've tried to bypass that. And sorry, Ryan, I know this is going to offend you, but this like that 12-hour wait to be seen in the ER, right?
Yeah.
Where people come in and they go, I sat in the ER for like 10 hours and nobody saw me. Well, we actually give you a little bracelet, and it has a phone number on it, and it's a direct line to that Joint Center. And what your job is, when you're coming into the hospital, you call that number, or you tell them in the ER, call this number. Because we've got people up there 24 hours a day that will come down and look. And they will communicate. They will communicate with the surgeon, and they will start talking about what things look like and what needs to happen. So there's a lot of things that we do preoperatively and intraoperatively to help control it. A lot of those things are out of your control. That's not things that you do. When we look at what you can do, you can tell us any of those high risk factors for infection. You can make sure that you take care of your wounds well. You can make sure that you're not exposing that wound early to a dirty environment, not getting it wet in that first 2 weeks while the wound is still fresh, and then communicating with us if you have a problem.
I think Dr. Gursky said that really well. There's one thing that I would add is that in most of the programs, we've found that skin prep before, so we'll have you do a body wash that you get sent home with from your pre-op, and you'll do that for the couple days prior to surgery. And then everybody sort of has their own prep in the room. We have standards for prep. I actually go ahead and prep my patient's skin again before we actually do the skin prep, and because it is that important. Okay.
I will tell you, we see very few infections in the ER because these guys are so good, but just good knowledge.
Hello. Could you speak to cartilage regeneration that seems to be advertised on TV and so forth? Is it hokum, or is there some science to it?
Can you say that again? Because
I didn't quite catch it.
something happened. We didn't hear you right at the beginning.
I think it's on. He's asking about cartilage replacement.
Yes. You mean
Cartilage regeneration.
Stem cells?
Regeneration, like the commercials on TV that say if you take this, you can regenerate. Yeah.
Okay.
I'd be happy to talk about that.
Have a seat.
So I think that there are definitely, the body has its own healing process, and we can take that healing process and concentrate it and put it in a syringe and stick it into your joint, and it may make you feel better for a while. But the analogy I use with my patients when they come in and they say, can I go to QC Kinetics and get my knee like all better? I would say, let's take some strawberries out in the street and run over them with your car and see what they look like, right? It's just going to smash them. And that's what our arthritic knee or arthritic hip, shoulder, that's what it does to those cells. They're extremely fragile. But I do think there is some concentrated anti-inflammatory chemicals, they're called cytokines, in those substances that can make people feel better. I've had patients tell me that they've felt better for a couple of years, but it did not put the cartilage back. It's just the cartilage metabolism is so slow, it's hard to do studies on cartilage because it takes that long to grow it. And so I caution my patients to be very pessimistic about their results if they go to one of those places. If you have the money, I don't think it can really hurt you unless they inoculate your joint with bacteria, and then you'll find us, and we will not be very happy. But I would be very cautious in my optimism about restoration of cartilage with anything other than cartilage transplants, and those tend to happen in very young people.
Right. And I agree. I don't really have a whole lot to add to that because that's absolutely true. If you want to break it down to a real easy science, to me, there's two choices when it comes to bad arthritic joints. We Band-Aid it up or we fix it. That's the bottom line. So all of these things that we talk about outside of joint replacement right now are typically termed Band-Aids. And I always tell my patients, there's nothing wrong with Band-Aids. As long as you know what you're doing and you know what to expect with it, that's fine. But don't expect the miracle to happen because we're putting a Band-Aid on it. We're just Band-Aiding up symptoms with most of those things. So only thing we know right now that will eradicate arthritic changes in the joint is a joint replacement.
I've had an experience with something called UC2. The article I read about it said it helped about 25% of the people. And other than that, I'm in that 25%, but I used to have substantial pain in my shoulder. And taking that seemed to have alleviated that. Maybe it was placebo.
Yeah.
I'm not familiar with that one.
No.
But there are a lot of substances out there that again, I don't think they can hurt you. If you look on the bottle and it says these statements have not been cleared by the FDA, it's usually in the supplement category. Almost all of them are going to be glycosaminoglycan. They're going to be some form of hyaluronic acid. If it makes you feel better, that is better than I can do. Right? I mean, it truly is, because what I do puts you through a significant risk, and it takes a significant amount of time to heal from, and it's a big investment. And so if those things are affordable to you and they make you feel better, I generally don't have a problem with it. But if you come to me and you say, well, I've been taking this stuff for 6 months and it's not really helping me, I'd say, well, we should probably stop buying it then. But if it helps you, it helps you.
Yeah. There's there's nothing out there study-wise that's shown it to be harmful, and absolutely. You got it right there? They make you feel better, so something good's happening.
Yes, ma'am?
I'd like to ask you about the useful life of a joint replacement.
It's a great question.
There we go.
So some of the very first hip replacements, there was a guy named John Charnley in England who sort of pioneered what we think of as the modern hip replacement, where we replace the acetabular side, the pelvis side with plastic, and we replace the femur side with metal. And there are some of those still walking around that were put in the 1970s, right? And then there are some that, I've personally had patients I've put a hip or a knee in and something happens and it only lasted 3 or 4 years. And so the components we think are better than they used to be as far as the molecular structure, on a chemistry level. They're more durable. I tend to tell my folks, as long as everything goes right, a hip or a knee should last you somewhere between 10 and 20 years. If you get better than that, then we won. We got a bonus. If it goes shorter than that, then we tend to ask questions about why.
And are there choices?
There are. Ryan and I use different knee and hip implants. I think most of them are on par, and it comes down to what you're most comfortable. I can predict to you how you're going to behave after surgery based on the implant that I use, and he can do the same for the implants that he uses. It's usually what you trained on and or something that you developed.
Right. And I think the key with that is understanding that just like there's 100 different cars out there, they're all made of typically the same materials, right? It's just how they're put together. There's little bells and whistles on each one of those styles of implants. But the bells and whistles aren't what makes it great. It's the backbone. It's the bones of the product that make something last. And the basic bones are going to be your titanium, cobalt chrome, and polyethylene plastic. Those are our major components in 95% of our joint replacements, barring hips, where we're actually transitioning to more of a ceramic surface for the ball that has a little more durability. But all of these companies, I always tell my patients, they're all good. They all make good products. I mean, we've all seen the ads and the lawyer things about recalls, and that's a possibility with any implant. We learn as we go, and so there are times when a company has taken a step to change something, and either it didn't work out or their manufacturing didn't work out. So what we typically do as surgeons is we really look for that product or that company that really has a strong history and has strong data to prove that they haven't had issues. So each one of us have kind of selected what we use based off of that, but the backbones of them are really the same. And so the surgeon that's putting them in is very comfortable with the bells and whistles of that product. And knowing the bells and whistles allows us to really modify that implant just for you. So it really gives us a lot of comfort and understanding of what to expect and what to expect from our patients and how to correct certain issues that are going on.
Next question. Also, what about cement and other ways to adhere?
So she asked, when it comes to, and we'll talk in both worlds, but she asked, how do you make the metal stick, right? What we've always heard is cement, but what else is there out there? And there's conventionally 2 alternatives when we look at joint replacements. It's going to be cemented, or what we call non-cemented or press fit, okay? So cemented means I'm going to use a product called polymethyl methacrylate, which is an old school dental bonding agent, but it's basically a medical grade cement that I can bond that metal onto the bone. We're going to get immediate bonding, right? That's going to actually occur before you ever leave the operating room. That will be bonded into place. When we look at knees, there is that alternative of going to what's called a press fit, where I'm using a product that has the potential for your bone to grow into it. Well, inherently, if I'm going to use that product, what do I want to make sure of? That you have bone that's going to grow into it. So it's usually restricted to certain ages and certain patients that have that potential for ingrowth, okay? So if you look at anybody over a certain age, we're going to typically go to that cemented prosthesis. If you look at the data, I think the cemented prosthesis typically gives you more durability and a longer lifespan when we've cemented. If you go to the world of hips, I don't know about you, Scott, but I don't know, I maybe cemented one hip in the last 10 years, maybe.
I agree with you on that, but I'm on like the other side of the coin. I'm a huge proponent of press fit knees. I've probably put 3,500 press fit knees in the past 10 years, and I've not taken any of them out for loosening from bone. But I'm like the extreme end of the spectrum, and if I can put my thumbprint in your bone, you're going to get a stem cemented prosthesis. But I've put a press fit knee in an 85-year-old, and I've had a 60-year-old who didn't have good enough bone for a press fit knee. So I go based on bone quality, not necessarily like patient age, but I agree that the bone is what we really depend on. But in a hip, outside of an extremely frail stovepipe femur, I would put a press fit every time. And there's some studies out there that say a cemented hip in elderly people with hip fractures tend to have less reoperation. I haven't really run into that, but so there's different, like again, just like we use different products, there are some different theories. It's kind of like, are you Baptist or are you Presbyterian? You know, we have different ways of our beliefs, you know, but it all ends up at the same place.
Here we're Catholic.
Yeah.
At the hospital. No.
I've been telling my best friend, you know, we all believe in Jesus, so.
All right, I gotta get my buddy in here.
I'm sorry, my question is about prevention. So if someone is just starting to feel bone on bone and we don't need a full replacement, is there something that someone can do if it's just a cyst or a small cyst or a bone spur? Is there something that we can do to eliminate that, or is surgery the only solution? I'm trying to think of prevention, being proactive.
Okay.
I don't think if once you start feeling it, the process has been going on for a long time. And then when we take an x-ray and we can actually see it on an x-ray, it's gone, right? And so I've got patients who weigh 100 pounds and have been physically fit and they eat right and everything about them, you'd think they live the perfect life, and they've got terrible arthritis. And so there's a bit of a genetic component to arthritic change. I mean, most people are like, yep, my dad had a knee replacement, my mom had a hip replacement. So there's some genetic component to it, but as far as prevention, it's kind of tough, right? I mean, you could say a person who, weighs 400 pounds might be more at risk for wearing out their knees than the person who weighs 100, but really, I see just as many people who are small as I do big that need a knee or a hip or a shoulder replacement.
And I don't disagree with that at all. I do, however, feel like there are things people can do to control their symptoms.
Sure.
So, if you look at his original slide, he said, what's the most common reason we replace the joint is pain, right? So I can't tell you how many times, and you've probably seen it too, a patient comes in, and what we typically do as surgeons, we want to look at your x-ray first before we ever see you. And if they have an x-ray up of both of their knees, and I go, oh, that knee is shot. That thing is bone on bone. And I go in and go, man, how long has your left knee been hurting? And they go, I'm not here for my left knee. It doesn't hurt.
Yeah.
And you go, oh, okay, your right knee looks perfect, right? So, some of the radiographs and some of the bone on bone can be utilized from our standpoint to understand the process that's going on, but it doesn't always equate to pain for everybody. And I think that patients that tend to maintain their muscle strength, I'm just a huge proponent of muscle strength. There is no doubt that your muscles are what help distract pressure from your joint. So your ability to maintain strength is highly important with this. So that is something that I harp on pre and post-operatively.
There's significant literature that supports activity even once you develop arthritic change, and we can see it on the x-rays and you're experiencing it, that if you stay active, you do better than the person who just goes and gets stove up sitting on the couch. And so I would agree with Dr. Gursky. I have a saying in my clinic, we treat people, not pictures, to sort of reiterate what he was saying, that your joint, the x-rays that we take corroborate your story. And so when we will have challenges when people come in and they've got a relatively normal looking joint by all of our imaging, but they hurt. And so those are actually harder, I think in my practice, are harder to deal with, because the worst thing that we could do is put you through the operative process and you have the same symptoms as you did before. That to me is a great failure in my diagnostic skills.
That's a great transition from my question. I'm post-op 1.5 and 2 years bilateral knee replacements. Neither of you guys or anyone at St. Francis did my surgeries. Still in pain. Still probably maybe an autoimmune that rose up after the surgery. At what point do you say stop being aggressive and trying to get treatment to stop the swelling? Did all the things you brought up there. Absolutely have to do rehab. It was remarkable. Can't recommend it enough. But when it comes to looking at another surgeon's work and maybe cleaning up after that individual, do you guys do that? Do you recommend it? I'm just looking for some help here. And I want to encourage you, if you're thinking about it, surgery, so many people do the surgery and they recover so well. It is a remarkable surgery. I don't want to interfere with that. This is just a unique situation to me.
Yeah, and so, yeah, no, it's unfortunate, you know, and absolutely, the first thing I will tell my patients if they come in, and I feel like I really try to exhaust the diagnostic process if they're still having problems. But if I can't solve your problem, I'm going to find somebody else that can look at it and put a fresh set of eyes on it. So second opinions, third opinions, why not, right? Before you go doing anything else, if we've exhausted everything, then let's get another set of eyes on it and see if there's something that we're missing here. I think it's rare, fortunately, but I think that it's very important that you get it worked up because there's reasons that we hurt. And sometimes we can find them if we just do the right studies and tests.
We're fortunate in Tulsa that we have a fairly collegial orthopedic group of people, even if you're not in the same practice. You know, I've got colleagues, Dr. Gursky and I have shared patients over the last few years. That I agree, just start over fresh and have somebody look at you. If you look at the literature on knee replacements in particular, we say that we get about 85% good to excellent results, and then 15% of people aren't happy about it. I think the majority of those people fall into an inflammatory category, like you mentioned. Then the question is, why are you inflamed? As we showed in those slides up there, we don't chop everything out and stick something else in, and so you still have your quad, your IT band, your hamstrings, your pes bursa, your prepatellar bursa. All of that stuff is still there. And if you had inflammation in it before, we can resurface and get rid of the arthritic change, but you still got all that soft tissue that can be inflamed. And so I would start with heavily trying to treat inflammation, and then it gets into sort of the minutia of why. The instability is another, you know, if you've got a little bit of instability, the knees will swell, they'll be painful. If you've got a little bit of scar tissue that could be being pinched between the femur and the tibia, those can be painful, kind of like biting your cheek. It just sort of stays inflamed. But there's things that you can do for that. With this knife IV wed, right? That's what I tell every one of my patients that I go to the operating room with. And if you don't break up with me, I won't break up with you, right? And so that as long as you keep trying, if you don't give up hope, there's hope. Yeah. Yes,
Dr.
ma'am.
Gursky,
Oh, sorry.
here I am.
Oh, yes.
Actually, you replaced both of my knees, one in 214 and one in 216. And I want to tell you that all the pain that I experienced up until then is gone.
That's awesome.
I have no knee pain even now. I want to know if the expected life expectancy of the knee replacement is 10 to 20 years. What happens when that time comes?
Right. And so that's good because, you know, like Scott said, you know, we expect them to last about this long, but there are hips and knees that have been in for 30 and 40 years. So we don't always have that predictability of understanding how long it will last. What is the way that I try to combat that? I follow my patients. So I continue to watch you. I continue to x-ray you. You'll come back consistently so that we can monitor and look at those x-rays and see if there's any wear or failure patterns starting to happen, because maybe we can intervene a little sooner, maybe we could prevent a bigger problem. But to tell you the truth, I probably push my patients more to that 20-year category, only because I've been doing this now coming up on 18 years. And so I'm looking at my patients now over this time period, and I'm looking at my revision rates, because that's what we do as surgeons. When we're out and we start a practice, we're doing a lot of the crazy stuff, but then we're starting to build this primary practice where patients are coming in and we're replacing one of their knees and they had a good outcome, and they come back to have their other one replaced, and then they talk to their friend at church, and so we start developing a practice. Well, what happens in that practice typically at 20 years is, I've been doing these joints a long time and they're supposed to wear out. And where are those patients going to come back to? They're most likely going to come back to me. So what we do is we kind of monitor our reevaluation rate, where patients are at, and I'm watching my patients at 15 to 20 years out, and I'm still not seeing a revision rate greater than about 5%. So although significant, and for those 5 to 10%, that's significant to them, there's still a lot out there that are now approaching 17 years that are still going strong. And we're not seeing any major wear patterns. I don't know that we can always predict who it's going to be either. I've tried, doing it long enough, I've tried to come up with every algorithm of who's going to be somebody that wears it out quicker, how it's going to happen. And I don't know that I've been able to come up with any true concrete answers as to why.
There are some things that if you're having trouble and we look at your x-rays, we do a lot of joint replacements. Between the two of us, we probably do close to 1,000 a year. And if you look at an x-ray and you see that there's malalignment of the components, those we can say, well, we got to watch this one a little closer. And if it starts to fail because it's overloaded on one side versus the other, that might require changing all the parts out. And we have options for that. But the most common thing to have happen in a knee is that the plastic bushing can wear out. And that's a pretty small thing to change. It's not as big as going through the original surgery. But if the metal loosens up from the bone, which is probably the second most common, it's called aseptic loosening, that tends to require a little bit bigger surgery. But it is fixable.
Okay, I've got one. I'm an autoimmune disaster. I have had Hashimoto's, I'm celiac, and I have rheumatoid arthritis. And through the rheumatoid, we've got it under control, but I was still experiencing pain. So then we figured out, got osteo. So I was a little concerned when you said that, I think it's Monovisc. I get the injection that's not chicken. He uses the bioengineered one.
Okay.
And you were saying that the insurance companies are getting to where they're not going to pay for
Yeah, he was. I'll reiterate that.
Yeah.
Is that all your question?
Well, here's the deal. I have done 70 half marathons. My last one was April of last year because my knees are not cooperating now. And about the furthest I can go is 3 miles. So like you were saying, I've kind of become a couch potato because I can't, and I've gained weight. So, and I know we don't want to do a knee replacement on me because of my age, but at what point do we go, I need to move, I need to get up and go?
So to answer your question, he is absolutely correct. What we're seeing in practice is this growing failure to get insurance approval for these viscoelastic injections, these
And
rooster
that's
cones.
work. So I don't understand why they don't want to
They can
pay
give
for it.
patients relief. We know they're not a cure, right? We know they're not a cure. We know they're a Band-Aid, but they can help. But insurances aren't seeing that cost-benefit ratio, probably. And so you're starting to see that decline. And it does become a big issue because it does push patients. In fact, I had one insurance say, we'd rather you just go have the surgery. Okay? So, and you think, why? That doesn't make any sense. But that is the way it's going. And the answer is, I feel like what you're seeing in joint replacement is this, over the last, would you say, probably 10 years, this real age discrepancy that's starting to happen. We're really starting to push this age up a little bit onto our joint replacements, partly because we're starting to see these 15 to 20-year studies that look at the survivability of the implant, but then we also look at productive years. So we look at patients that go, I'm in my mid-40s, late 40s, I know that this might not be the only surgery I have, but I can't go to work. I can't function, right? My job is to be up and moving, and I can't just go get a job where I'm sitting down. How am I supposed to do this? So your productive years are very important. And so for some patients, they have to make that leap into the corrective side of it, understanding that there's going to be some consequences potentially with that down the line.
Okay, thank you.
All right, we're coming up on the hour, but we have time for some more questions.
That's only been an hour? I feel like my mouth's dry.
Do you guys do the robot-assisted surgery?
Great
Yeah.
question.
I'm a fairly heavy user of one of the platforms. It just so happened to be the platform that worked for the knee that I already used. I would say, again, the robotic platforms, because there's several, probably all get you about the same place. It's how they work in your hands. And so I'm a proponent for one called Mako. They're pretty heavily advertised. They've got a strong company behind them, to do that, and they've got excellent support. In fact, my Mako excellent support is sitting in the back of the room back here. He's exceptional. He takes care of me, and I can trust that I'm going to have what I need for you in the operating room, no matter what, because I've got that support. But I think the robotic, I tell my patients, because for a long time we didn't have them everywhere. And maybe your insurance required me to go to a certain facility, and we didn't have it at that facility. So I tell my patients that the robot is a tool in my tool belt, and I'm like a carpenter, and I've got a chisel and I've got a saw. I can do the same thing with those two different things. It's just a little bit different, but I can get the same result. So I don't depend on the robot, because heaven forbid, what happens if it shuts off in the middle of the case, which can happen. Right? And so I still need to have the skill and the knowledge and the expertise, the experience to be able to get you what you need. But I think the robot's a very helpful tool in certain scenarios, certain deformities, certain prior hardware, you've had previous surgery, something like that, where traditional methods of aligning the prosthesis are going to be challenging or impossible. And so I think it's an exceptional technology. It's getting better. But it is not necessary to get you a good result.
And I am not a big robot user. I'm certified and I do use the robot. I will reiterate with him that it's usually going to be more on my big deformities. So it's going to be these things that it's difficult to understand positionally how much bone you've lost, and there's positions where the robot can be very important. But I think the biggest pitfall anybody can do, and Scott is not in this category, so I'm not bagging on him at all, but it's the ones that go, I will never do it without a robot, because you're losing some of that technical feel of the surgery. It's the feel. I know what the saw is doing in my hand. I know where I'm at. I know what it's doing. I know what I'm cutting, and I don't know that with the robot. The computer screen's telling me what it's doing, but I don't know it. I can't feel it. So for me, it's a very tactile thing. I want to feel exactly what I'm doing and what's inside of there, but I do utilize it when I need to. And so I think it does have some pretty incredible applications, and I think they're actually coming out with the revision side of it, I think, pretty soon, and that's probably going to be even more applicable for me.
Well, I would tell you, getting halfway through a robotic knee, that is not knee replacement, and it turns off, or you have an array, pop off, or it loosened up because the bone wasn't hard enough to hold the tracking arrays. That's not knee replacement 101 at that point. You better know what you're doing to be able to, get the patient where they need to be. And so, it is a great tool, but again, it's a tool that we use. Yeah. Over here.
I need to get my steps in tonight, so thank you.
I have two questions. One, first of all, if you're having an issue, do you start with your primary care physician, or do you just call your practice? What do you do?
That's a great question. So I think it's probably it's highly dependent on your insurance.
Yeah, it depends.
Some require that you go to your primary and you have a referral. Some do not. I think as specialists in the world of joint replacement, we get honed in on very specific patients that already have a diagnosis. They already have the problem. They've already been treated maybe by another physician. And a lot of times they're coming in, they're ready to have surgery. But it's not all of our patients. So I get patients that just self-referrals that come in and go, my knee hurts. And so What we're in the job to do is to take care of patients who have those problems in those joints. And I don't ever want to get pigeonholed into that attitude that I just don't want to see anybody unless they need a joint replacement. I do lots of things other than joint replacement to try to treat patients. So I don't ever want to get into that habit. So for you, it just depends on insurance. There's a lot of accessibility to getting into bone and joint, and Warren Clinic, which will now be, one big happy family. We have lots of access points.
And my other question is, I am having knee problems, pain, but it's not consistent. Like I can go for weeks and not have any problem, and then I'll wake up and it's hurting, and it'll hurt for 2-3 days. Then I'll go again for 3 weeks or so, and nothing. Is that just maybe overuse, you think?
It can be a lot of things. And I think if it becomes a consistent pattern, that's when you get evaluated.
So just kind of wait until it's consistent?
Most things that wax and wane are inflammatory, but it could be, you could be like Dr. Gursky mentioned, you could have a knee that's really, really arthritic on x-ray and it not hurt, but sometimes it does, and then sometimes it doesn't. And so,
Well, I did have my left knee replaced 12 years ago, and they told me then that my right one would need replacing, but it's not bothered me until just this year.
Yeah. So it probably warrants an evaluation, right?
So
An evaluation does not mean you're going to surgery.
See,
Evaluation.
that's why I don't want to go in, because I don't want to.
Because you think somebody's going to push. Yeah, and I think that's very clear, probably an important thing. And I think I've heard a lot about Scott Reed and how he practices, and I think he practices much the same way that I do, and that is surgery is still our last resort.
Yeah.
Okay, it's not come in, let's sign you up for surgery. It is assess what's going on. What can we do to make you feel better? Are we at a point where we've got to change something? Right?
I will never, ever tell a patient, you need a knee replacement, right? Because I don't know that. You know when you need one, right? I'm going to tell, my job is to educate you on what it is, what to expect, and then when it comes time for surgery, to be the best, technical surgeon that I can be, and then to try to help you through that process afterwards, encouragement and making sure that you're with the right people. But you almost have to talk me into it, right? You have to prove to me that you're ready mentally, emotionally, your social support is ready. And the line that I use is, if you wake up every morning and you think, oh man, I'm not going to be able to go to my grandkids, to the pool, to go shop with my girlfriends. I'm not going to be able to do these things. My men patients, I always ask them if they're a Super Bowl fan, and if I gave them tickets to the Super Bowl 50-yard line, but you have to park 10 miles away, are you going to take them? And if they tell me no, I'm like, well, maybe you're ready. But like, you almost have to, it's not that we want you to suffer to offer this to you, but we want to make sure, A, we have a chance to make you better, right? And B, you're at a point where you're ready to accept the risk, because the risk is real. It's low. It's extremely low, but it is real, and it's emotionally challenging when patients struggle. I probably won't live as long as I could have if I'd have been a different career. It's a stressful thing. We take care of people who have big problems, and it doesn't always go right. And when that happens, it's a hard thing. It's hard for you. It's hard for us.
And like you said, it's a 50-50 thing. Like, it's a marriage thing, right? So and that's what I tell my patients. This is 50% you, 50% me, right? We've got a job to do, and that job is to put in the best joint that we can put in that's going to function and do what you need. But then you've got the other 50%, and that's both emotional and physical. So people that aren't ready, they have to be talked into it. You have to tell them, this is what you've got to do. You don't want to do it. You don't want to do it in that situation.
If you haven't noticed, we have a lot of sayings, right? Because it's just easier for people to remember our sayings. And one I've become fond of telling my patients lately is I said, no matter how, if you do exceptionally well, I should get 10% of the credit, right? You should get 90% of the credit. I should get 10% of the credit. Even, I did a great job for you. You get 90% of the credit. But that goes for the adverse too, right? If you do poorly, I get you 10% of the credit, and you get 90%. So. But truly, it is a partnership. It takes me about an hour, to do a knee replacement, right? It's a big surgery, but we've done so many, and we have the process down. We know how to do it. My PA right here, Luis Hernandez, everybody comes in and goes, Dr. Reed, you did such a good job closing my knee. And I'm like, it was Luis. It's a process, it's a teamwork. I get you for about an hour, and then you get it for the rest of your life. And so it's really that we will do everything we can to make sure you're successful. But really, I mean, the people who are most successful are the ones that put in the time and the effort.
Oh, I think she's got the microphone back here, I think.
I just have a quick question. I have two coworkers that recently had partial replacements, and they both had the Lavera shot a couple weeks before. Can you explain what that is and if it's successful?
Do you use iovera?
I don't use iovera.
Okay, so we use iovera. Luis, in fact, does our iovera for us. What iovera is, it's called cryoanalgesia. So we'll numb up several of the sensory nerves around your knee. We then insert a little probe that's hooked up to a nitrous oxide canister, and we freeze a little small area about 4 or 5 millimeters in diameter around that sensory nerve. It interrupts the fibers within the nerve tube. It doesn't cut them off, it doesn't burn them, it doesn't cut them, but it interrupts the inner fibers, okay? Over a period of weeks to months, those fibers will regenerate. We think that it's about 70 to 80% successful in reducing the amount of pain people have in the immediate postoperative period. It's not a guarantee, right? It's just something we can try. In our practice, we give narcotic pain medication for up to 3 weeks. And then after that, because there's a lot of literature that says narcotic pain medications after joint replacements tend to start losing their efficacy, by that time. So we're looking for alternatives. What we've found since we've started doing iovera in our practice is that people tend to call in for less pain medication refills. But there's also a lot of just education about pain medication. So there could be, and I'm not doing a pill tracking, study to look at this, but we think we're putting out less pain medication refills. The problem with iovera, kind of like the problem with viscosupplementation, is there's very few of the commercial insurers will pay for it. And so we can get the kit and do them. It's about $900 to the patient if their insurance doesn't cover it. Medicare will cover it, so if you're a Medicare patient, and then it's an access issue, if we've got time and space available for you. So I've done thousands of knee replacements without iovera, and those patients are doing fine. And then, over the last 18 months, we've started doing them, and I think it helps, but it's not a guarantee. Oh, yeah.
If you have an arthritic knee and it's been that way for a long time and it's not painful, but you keep walking on it, does it matter how long you go? Do you do more damage to it? Is it more difficult to replace later on?
That's a great question because, probably the best answer would be to go back to his lecture and you see the guy that had he showed you the knees and how deformed they were and looked like the femoral condyles were past where the shin bone sits. And so what happens in the arthritic process is it's very staged. We lose our cartilage, we start to approach bone. We get bone contact, right? So we have bone exposure, then bone contact. Well, if we get to that stage and we go, look, it's not hurting me, I'm going to keep walking, I'm going to stay active, I'm going to do things. Yes, activity is good, movement is good, but yes, we will continue to wear. And I always tell patients that in that process of band-aiding up, even if you're having some symptoms and I'm band-aiding you up, the process is still occurring. We're not halting the process in the band-aid treatment world. Eventually, you will start to lose bone. If you start to lose bone, you start to create deformity. You start to create deformity, you start to create soft tissue problems, and that's imbalance in your stabilizing ligaments. So when we look at patients that come in with bone-on-bone arthritis and it doesn't hurt them, then we're really starting to focus on stability. Because that's the second thing that really, to me, is very important in the indications for joint replacement is joint stability. And everybody will say, I noticed that my knee wants to give way. Well, those are your ligaments. That's your knee telling you that the stability isn't there. And if we start to affect those ligaments, then we have to try to make that up surgically. And when we have to make up bone defects or bone deformity or bone loss and ligament instability, well, it really heightens the procedure. Suddenly you're looking at prosthesis like these real dramatic ones that Dr. Reed had up, where we're putting a lot of metal in. I always tell patients, the more bone you lose, the more metal I'm putting in. I can promise you, you're going to have more metal than what you would otherwise expect. So
those cases are harder. They're harder to balance. They're harder to make up the bone. They're harder to make last. they're kind of fun for me. I'm like, well, I get to use all the tricks I learned in training. But we will, to Dr. Gersky's point, usually those folks who don't hurt, they end up falling, right? They go, well, it didn't hurt, it just gave out on me. And then they've broken their shoulder or they broke their hip, they hit their head. And that's stuff that we don't want to have happen. And so it's a balance, right? It's a balance between what is the risk of the surgery, what is the risk of not doing the surgery, my symptoms, and we just have to kind of play that out. And that's where I think you start a relationship with a surgeon or your primary care or somebody who can watch you and sort of assess your risk for bad things happening. And then you kind of know when you get to that point.
Okay, thank you.
Yeah.
Well, thank you everybody so much for coming tonight. Thank you, Dr. Gursky and Dr. Reed. And then I have a great Labor Day weekend.
That was good, man.
That was pretty good.
Yeah.